Good morning, everyone. Happy Friday. It's fall, and welcome to our COVID community of practice for community family doctors. We're delighted to hold these series of sessions together with the Ontario College of Family Physicians. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the University of Toronto Department of Family Medicine. I'm going to turn it over right now to my colleague, Dr. Jennifer Young, the President of the Ontario College.
Hello, everybody, and welcome once again. I think this is our 9th gathering of exchanging knowledge from our own practical work. Today, we're going to be talking about COVID-19 and considerations as we plan or are in the fall 2.0. We had a really lively session, the last one, and this will be some of the same material, but updated information as we have received it. Myself, David Kaplan, and Jeff Wong will be the panelists, and with Tara, we'll be answering the questions that you've sent in to us. It's a 1 credit per hour program, and we're delighted to share this opportunity to speak with you all with the Department of Family and Community Medicine at U of T. I'd like to go to the land acknowledgement now, where we acknowledge that the land on which we're hosting this meeting is a traditional territory of many nations. We acknowledge that Ontario is home to many diverse First Nations, Inuit, and Métis peoples, and that each of you are joining us from one of those many traditional and treaty territories. We are grateful to be able to come together in this way.
I find that the land acknowledgement is a wonderful time for us to just reflect on the injustices done to Indigenous people in the past and continue to be done in the present. And September 30th marks a particularly important day, especially as so many of our children have headed back to school. It's an important time for us to reflect on the legacy of the residential school systems. And in fact, learning about the residential school systems is one of the commitments laid out within the Truth and Reconciliation Commission document. And it's wonderful to see my own children learn more about this in a way that I never did. So I'm just sharing with you here some great resources that were sent along by our Indigenous lead, Suzanne Shush, places where you can get the orange shirt that support organizations that are doing great work in the community. All of this is also available on the Women's College Hospital website, and they're a great article that they put forward for this time. So as Jennifer mentioned, we're delighted to welcome you to this 9th session. We've designed it always as a place for us to come together and learn from each other. We know that we're working in uncertain times, and not any of us necessarily may have the quote right answer, but together, hopefully we can find a way and figure out what it is that we need to do to provide the best care that we can and look after ourselves and our communities. Previous recordings can be found on the website below, and so this recording will be posted there along with the resources that we mentioned today. I wanted to acknowledge our planning committee. The planning committee, together with myself, we select the participants, and always interested in your feedback on this. So I'm delighted to introduce our panel today, Jeff Kwong, Jennifer Young, and David Kaplan. We've had them here before, but last session was so popular, we wanted to repeat it and provide some updated information. So I'm going to turn it over to them one by one to introduce themselves, speak to their disclosures. Jeff Kwong.
Hi, thanks, Tara. So I'm a clinician scientist. I'm based at Toronto Western Hospital as a family doc, and I also work at ICES, Public Health Ontario, where I have received salary support from both of those organizations. I have research funding support from CIHR, Health Canada, and the US CDC, and I receive a speaker's honorarium from Ontario College of Family Physicians.
Jennifer?
Yep. I'm Jennifer Young, I'm a community family physician in Collingwood. I have no relationships with financial sponsors, and I'm the current president of the OCFP and get a speaker's an honorarium for that, not a speaker's honorarium.
David, do you want to go ahead?
Sure. I'm David Kaplan. I'm a family doctor at the North York Family Health Team in Toronto, and I am the Chief of Clinical Quality at Ontario Health, where I have responsibility also for primary care. For the last 6 or 7 months, I guess, I've also been the primary care COVID lead for the Toronto region at Ontario Health, and I receive, I'm an employee of Ontario Health, so I receive salary support and I receive a speaker's honorarium from the OCFP.
And as mentioned, I'm Tara Kieran, and I do receive funding for research for my own salary support and also for grants. All of these are from nonprofit associations, with the exception of Gilead Sciences, where I have a grant to cure Hep C within family practice. I am delighted, though, to also welcome all of you who are coming from different regions of Ontario, obviously the GTA, but also Ottawa, London, Goderich, Uxbridge, Stratford, Grand River, so many different places, and you're a great part of our community of practice. So I do want to just review how you guys can participate. So on the next slide, you'll see that you can either participate by the chat or the Q&A, and I'll tell you what we prefer. So if you're able to post your questions on the Q&A, that would be the preference. In the Q&A, our panelists, Jennifer, David, and Jeff, can answer the questions by typing, and we can keep track of them very easily. If you see a question in there that you like, just give it a thumbs up, and then we know to prioritize it, because it may not be possible to get to all questions, although we'll do our best. Sometimes a topic comes up and you actually have something wonderful to offer us, a suggestion of sorts, and I think it would be great if you could post your suggestions or your thoughts in the chat. So please go ahead and post your suggestions or thoughts in the chat, but if you have questions, put them in the Q&A. So, without further ado, I'd love to welcome Jeff to start us off. We got a lot of questions from you in terms of informing the content of this panel, and so many of you are wondering, what is flu season and flu shot season going to look like for us in the next little while? And we're hoping, Jeff, that you might be able to provide us some insider knowledge that you might have around what provincial plans might look like this year for the flu shot, and how can family doctors prepare to deliver it within their practice?
Yeah, thanks. Yeah, so the information I'm going to present today is not confidential. It was presented earlier this week at the Grand Rounds provided by Public Health Ontario by my colleagues, but it hasn't been posted yet to the Ministry of Health website. So that's why I'm not sharing slides yet. Information will be coming out soon officially, but I'll give you all the, the official word that just hasn't been officially posted yet. So this season, I'll start with the bad news. Unfortunately, we won't have a flu mist available to us. That's the live attenuated influenza vaccine, the intranasal spray. Unfortunately, we don't have that available in Ontario this season. But the good news is that we are getting a new product that's called the cell-based influenza vaccine. So in addition to the regular egg-based influenza vaccines, there's a new product called FluCellVax that's manufactured by Securus. That's, they, instead of growing the vaccine in eggs, they actually grow it in mammalian cells. And so this is a product that's been around for a while in Europe and the US. It's been used since like 2007 in Europe, and a few years later in the US, and has come to Canada now. So it's not, it's the same sort of product. It's a quadrivalent vaccine, just like the egg-based one. So it contains 4 different components. There's an H3N2 component, an H1N1 component, and then 2 B strains, one of the Victoria lineage and one of the Yamagata lineage. So, so basically in those who are aged 6 months to 8 years, we can give them the egg-based standard dose quadrivalent vaccine. And if they're 9 years or older, they're eligible to get the cell-based quadrivalent vaccine. Now, for those who are over 65 years or older, we recommend giving the high-dose vaccine. So the high dose, it's only a trivalent vaccine, so which only includes 3 strains, but it includes 4 times the amount of antigen for each of the strains. So the standard dose has 15 micrograms of antigen of each of the components, whereas the high dose has 60 milligrams. So it's 4 times the amount of antigen for each of the strains that it contains. Unfortunately, it's not quadrivalent yet, so the high dose is only trivalent. So there's only 1 B strain, but it's felt to be that there may be some cross protection between the 2 lineages of influenza B. So that's why we might be able to get away with it. But the advantage is that it is more effective than the standard dose. And especially, for our elderly patients who are more susceptible to H3N2 influenza, it is more effective, against the H3N2 component. And so that's why it's recommended for those who are, 65 years or older. And if there is a situation where you've run out of the high dose vaccine, it is okay to give the standard dose quadrivalent vaccine to older patients. There have been no head-to-head studies comparing the high dose trivalent versus the standard dose quadrivalent, so we don't know which one is better. We know that this high dose trivalent is better than the standard dose trivalent, but that added strain maybe offers some more protection in the quadrivalent. And the other good news is that pharmacists will be receiving doses of the high dose vaccine as well. So your patients can get the high dose vaccine through pharmacies this year. Once again, the pharmacists are allowed to immunize those aged 5 years or older. So that's another place you can send your patients to if you're not able to vaccinate them yourself. So what's new also about this year's vaccine is that they've changed up a number of the components. So actually 3 strains out of the 4 in the quadrivalent are new this year. So they've changed the H3N2, the H1N1, and the B Victoria lineage strains in the vaccine. So, this might be a good year to get vaccinated because there are new strains that have been included in the vaccine. Not to mention, trying to prevent influenza, so that we can have one less virus to worry about this fall. So that's all I'm going to say about the flu shot for this year, and happy to answer questions that come up in the Q&A when others are speaking. I'll talk a little bit about the flu shot clinics. So Brian, if you could put it to the slide about the guidance. So here's an excellent document put out by the National Advisory Committee on Immunization, where they provided some tips on how to have flu shot clinics during this pandemic. And they give some very practical tips about, obviously we want to screen people, make sure they have no symptoms before they come to get vaccinated. You might want to set up appointments instead of having like long lineups of people like dropping by. And you want to, maybe have your clinics held over longer periods of time so that you can spread people out. They give tips about, physical distancing, infection prevention and control. So make sure, you have PPE for all staff members, as well as having the people patients coming in to get vaccinated, wearing masks. And it's not necessary to wear gloves while vaccinating. You just have to wash your hands in between patients and, wipe down the surfaces that they may have touched. So like very practical tips like that. And if you want to hold drive-through clinics, that's another option. They touch on that a little bit, and they provide some resources at the bottom of this document, as well as we were going to provide some during this webinar. So I'm going to ask to go to the next slide. And I think, Tara, did you want to cover this section here? Tara, I think you're muted.
Jeff, thank you so much for going through some of those, the updates to what we can expect this year. And you've done a fantastic job telling us sort of how we might be able to plan our own flu shot clinics. I think there are questions in the chat about, are family doctors expected to provide flu shots? I mean, I think we are encouraged to do so, I will say. And then there is a question, will there be clinics run by public health?
Maybe I'll speak to that. Or Jeff, you want to go ahead?
I believe public health will also be running clinics as well.
So yeah, for those of people who live in the city of Toronto, public health is looking to run 4 clinics, one in each quadrant of the city. Public health runs those clinics 1 day a week in each location. So those clinics actually have quite limited capacity, but they will be running. You must contact your local public health unit. Different public health units are doing different things. And it's all about whether or not they have the capacity given the redeployment of staff for COVID-19.
So interestingly, we already have some messages in the chat that Hamilton and Halton won't be running public health clinics for the flu shot. So thanks for letting us know. And they haven't been for a couple of years. So I'm going to just ask Brian, are you able to take us to this Center for Effective Practice website? So this is a great resource that I just wanted to share for folks. We'll get to a few more of your questions. But for those of you, it's the one on the very end, Brian, the Center for Effective Practice. Yeah, perfect. And if you haven't been here already, the Center for Effective Practice does have fantastic tools to support family doctors. If we scroll down, we'll see that there's a section called Planning for Fall and Winter, and we've opened that section so as we scroll down, you'll see some more. And then if you keep going, you'll get to a point in the section where it says October to December, prepare for flu season. And there's, again, a lot of really practical tips here. They also include, some interesting advice, I think, from the Ministry of New Zealand around potentially shortening waits for post-immunization that you could consider. And they also have details on the drive-through vaccine clinic. You can keep going maybe a little bit. Yeah, so if you click yes, Brian, here where it says, does your clinic have the resources, you'll get a lot of the resources that the practical tips we just talked about, as well as links to other resources. So we can go back to the main slides, and I think the other thing we wanted to share with you is just some resources around specifically drive-in vaccination clinics. So if we go to the next slide, Brian, we can also share that link in the chat, and maybe I'll turn it to you, David, to speak to the drive-through vaccination clinics.
Sure. So I just shared another link in the chat as well. This is advice from Australia for GP practices considering influenza-based or vehicle-based influenza clinics. Obviously, all these things are looking to minimize the amount of contact that people have, cleaning in between surfaces. I think the the idea would be, though, to try to have it in a parking area close to our practices. I guess just in case you needed additional supplies. Really, the main important thing, I think, for most of us is to ensure that we have some multiple parking spots to ensure that we can actually have people stay there for 10 or 15 minutes, depending on which advice you want before they go off. I think one of the major concerns that some people would have is if people have a vasovagal episode following, if they're in their car following having their shoulder poked, really need to think about what you're going to do with sharps as well, obviously. Ideally telling people, I think one of the most interesting things is, making sure that people are coming with something that they can actually roll up their sleeve. If they're in the car, it's going to be really difficult if they start having to kind of undress and pop their shoulder out. I think that the main, idea with all of these things is to move away from having long lines of people at our offices waiting for flu shots. and to really not bring people in just for flu shots unless we think that is appropriate for them. I know that, and we'll try to get them posted, that AFTO is trying to create some queries to help us identify who the patients are that we really want to ensure also get flu shots this season. I want to add only one other thing that's not related to drive-through vaccine clinics. As those of you of the 256 who are online who practice in the city of Toronto, as you know, we get our flu vaccine a little different than the rest of the province. We get it shipped directly to us from the Ontario government pharmacy. There's an auto shipment based on if you gave flu vaccination last year. That auto shipment will happen this year again, unless you tell public health or the Ontario government pharmacy otherwise. So if anybody who is on the call knows that they will not be giving flu shots in their office, please, if you let me know, I'll let public health know on your behalf. We're just trying to make sure that we don't try to deliver vaccination to practices that, one, aren't going to be giving flu shots, or two, have closed. And if you are closed or aren't able to, we're also really willing to help you link up with your local sub-region or Ontario health team to see if another practice can help cover you.
Thanks, David. There are lots of questions that have come in, and Jeff, maybe I'll address a couple to you. So there's a popular question here about for the non-egg vaccine that is available, what would be the purpose to give this new vaccine versus giving the quadrivalent flu vaccine?
Yeah, so the cell-based vaccine is also quadrivalent vaccine, but the advantage of it is that it's felt to be, it's exactly the strain that was recommended by WHO when they make the recommendations in February of what strains to include in the vaccine. What a lot of people don't realize about the egg-based vaccines is the process of making the egg-based vaccines, because they have to grow it in eggs, sometimes the virus can actually mutate in the process of growing in eggs, because sometimes they have to passage it through several generations in eggs before they can get one that grows well in eggs. And so there was at least 1 year where we had lower vaccine effectiveness because the strain that was in the vaccine after it had been grown through eggs was actually different than what was recommended by the WHO, when they did the strain selection back in February. And so theoretically, we think that the cell-based vaccines won't be susceptible to this and may have slightly higher vaccine effectiveness than the egg-based vaccine. There's no studies to show this yet, but that's kind of theoretically the advantage of the cell-based vaccine. Both are safe for patients who may have egg allergies. So there's actually no evidence to suggest that people who have egg allergies, are at increased risk from receiving an egg-based influenza vaccine. So it's safe to give either product in those who have egg allergies. And then to answer another popular question about how long people should be waiting after getting flu shot, the official advice is still 15 minutes, to make sure they don't have an anaphylactic reaction. I think there are some people suggesting, out there suggesting that maybe we can shorten that, for people who have received, flu shots in the past and have had no problem, maybe we can shorten it. I think it's going to be a little bit of a clinical judgment involved there. But I think from the perspective of trying to maximize physical distancing and the flow of the clinics, it may be, necessary to try to reduce that, 15-minute wait period, unless you can find, unless you have enough space to, to house everyone to be physically distant and waiting for 15 minutes.
Thanks, Jeff. There are a couple of other, some quick and some popular questions. So is there a plan to decrease the age of children that pharmacies can give vaccines to?
So I can speak to that. Yeah. So
I'll let you go, David.
Yeah, go ahead. Yeah. So there is a, I don't think it's going to happen before flu shot season, but there is a regulation before the Ontario Cabinet to allow pharmacists to immunize children down to the age of 2. It's gone through its 45-day period where I guess there's a public consultation, but Cabinet still has to passed the regulation to allow pharmacists to administer vaccines down to age 2. I have tried following up a number of times to see if this could get changed. I think this is a real barrier for a lot of families. It would be great if a whole family could just go to the local pharmacy and get their flu shot if that's convenient for them. Jeff, I don't know if you know anything more than that.
No, I know there were discussions about having it, but I don't know if that's going to be happening this year. As for the question about when the flu vaccine will be available, unfortunately, I haven't heard anything either yet. I hope that it'll be sooner than in previous years, or, slightly earlier, so that we can have clinics earlier. But I don't know when that's going to be, unfortunately. I think we should just plan and just get things, the logistics ready, and then once they let us know when the vaccines will be delivered, then we can start rolling them out.
There are a lot of questions that have also popped up just around the rationale for why using the cell-based in the older age group, 9 and plus. Why do the younger kids get the egg vaccine only? Yeah,
it's only licensed, approved for use in those 9 years or older. I don't know why it's not approved for use in those under 9, but for whatever reason, that's just what's the, what it's licensed for. So I think if you gave a cell-based vaccine in someone under 9, that would be considered off-label usage of the vaccine. But I'm not aware of any safety data, that says it's contraindicated in those under 9.
Okay. So those are a lot of the questions that have come to date. I'm going to switch gears a little bit here, and I know that some of the answers to the questions are also in the Q&A. So if audience members want to look at the answered questions, please do that. But I'm going to actually shift focus a little bit, because the other thing that we got a lot of questions about in advance of this community of practice was related to what do we do about patients who have upper respiratory tract infections, sniffles, cough, cold. We expect that in the flu. Not all of this is going to be COVID, some of it is, but how do we plan and do things in our own clinic? Should we be seeing these symptomatic patients in our clinic? Will there be set up of respiratory assessment centers in the province to enable family docs to make it easier for family doctors? So David, I wonder if I could throw that question to you, and if you could provide an update and some insight to our audience.
Yeah, sure. I just want to make sure I'm not on mute. Good. So I guess it's a two-part answer. The first part is, across the province, we have 150 plus what people refer to as respiratory assessment centers. I like to call them COVID assessment centers. I like to call them COVID swab centers or swab collection centers. I'm not sure they're meant for assessment. I think there's two things that are going to be, hopefully, that we're going to see over the course of the next 10 to 14 days. One of them is, and I think the Premier touched on it, expanding where people can get their asymptomatic COVID swabs done. So we know that probably up to 2/3 or more of patients who are getting COVID swabs don't have symptoms. And so obviously that's eating into a lot of the, 20,000 asymptomatic swabs a day is eating into a lot of the people who could be getting swabs done if they have symptoms. And so with an expansion and moving asymptomatic patients out of these typical settings, it may allow us to rethink of what assessments mean. If you want a great example, and I'll post the page in here in the chat. William Osler Health System has already announced, and I believe they're up and running. I think they're on day 3 of their clinic. They have a COVID-19 cold and flu clinic, and they're seeing patients, anybody with any new COVID symptom. And on their website, they have, who's supposed to go where. So at their Peel Memorial Center in Brampton, that's where their COVID, flu, and cold clinic is. But if you're just looking for drive-through testing, they have their usual locations for their drive-through COVID-19 clinic. So I think we're going to be seeing a little more announcement over the next, I would hope, week and a half to 2 weeks. But I do think it's important to ensure that people have a place that is, not just appropriate to get assessed, but also is patient friendly. Because the default now would be likely, a patient calls your office, they have, let's say, a fever and, loss of taste and smell, and you would likely send them to a COVID swab center to get their COVID swab, have them wait 24 to 48 hours till it comes back, and then see them in the office if you felt that an in-person visit was necessary. It would be nice for these patients to be able to be seen with one visit if they needed an assessment. So I think more to come.
Thanks so much, David.
And I'm sharing that now on about William Osler. If there's other communities that are looking to do the same thing, I suggest that they connect with the folks at William Osler who've already set one of these up.
Yeah, thank you. That's really helpful. So we continue to get some questions just about the flu shots and pharmacies versus the clinic. There's some questions. Do people have to pay to get the flu shot at a pharmacy? And when they, will they be able to safely get the flu shot at the pharmacy, given that some of the pharmacies are so small? And one person commented that, can the OCFP strongly encourage family doctors to provide flu shots? The clean environment of a doctor's office has advantage, I think, over the pharmacy. So that's what, maybe I'll turn it to one of our panelists to answer some of that.
Right. So thanks. Thanks. I typed a quick answer there, and I would say that we are encouraging family doctors to see in-person visits that are appropriate and using appropriate PPE to doing flu shots it's difficult to strongly encourage that if the logistical parts of someone's office make it really challenging to do so in a safe way. Absolutely, if you've got more space, you can do that. You have more capacity for a flu clinic. We are encouraging people to spread that role if they cannot do it in their own clinic, to encourage connecting their patients to all the other options that are available in their communities.
Thanks. Some interesting comments back from some panelists. Nancy Fitch states that in rural Ontario, our assessment centers are true assessment centers. We book 20-minute appointments for patients who need to be assessed versus those who are booked as drive-through swab only. And then Ross Kirkconnell mentioned that in Guelph, the COVID assessment center has since day one had 2 streams, assessment and treatment, chest x-ray, throat swabs, prescriptions, all done out of the assessment center. So yes, that does seem, I would say, different than I do work at our COVID assessment center here in Toronto, and the one I work at, it is not an assessment center, it is more like a testing center, and I think that is the norm in downtown Toronto, so there's variation certainly across the province. Jennifer, I noticed that you also answered some questions about back to school and who can be cleared for back to school. I wonder if you wanted to just speak to that briefly.
The back to school guidance is, I just sent out a letter to the membership, so that that's a key part of it. Back to school is, you'll need to test people who have symptoms, and runny nose in the absence of any other symptoms, and which could be explained by seasonal allergies or postnasal drip, is excluded on that list of symptoms. That being said, testing for children who have, let's say, runny nose plus is required. The clearance is if they are negative 24 hours after symptom resolution, and that prolonged drippy nose after a cold is one of those gray areas of being asymptomatic. The other part is if they're COVID positive, they need to be isolated for 14 days. If they're in contact with somebody who has COVID, they are also 14 days isolation.
Thank you, Jennifer. So some
And
more
sorry,
comments
I
coming in.
do want to say,
Oh, go ahead.
Sorry, I do want to say one thing. There was just a guidance coming that came out that's confusing, because parents are being said that they can send kids back when their symptoms are improving as opposed to being asymptomatic. And that we will take back to those who published that to the Ministry of Health to say that that is in conflict with the previous guidance, which is asymptomatic for 24 hours, and indeed very confusing.
Yeah, so, thank you, Jennifer. It's interesting. I mean, one also big issue seems to be just the regional variation in the assessment centers. We're getting more comments in. David Dane is saying across a number of communities in OH Central, there's going to be RESP assessment clinics, which is great. Elaine Blau, though, saying, I'm in a rural area and our assessment center is swab only, and it's a 3-hour return drive for many people in the community. So their fit is really needing to step up. And then Alan Grill mentioned that in Eastern York Region, North Durham, OHT, they are going to be opening up a respiratory illness clinic as well. So this is, and then Jennifer, somebody did mention to say thank you for bringing up the inconsistency in the screening tool, major issue. Yeah, so we need our tools to be really consistent and clear. Jennifer, I'm going to throw you a different question though, because we have in advance of this call gotten a lot of questions, and there is a question up posted as well about sick notes and workplace accommodation. So, what's the role of the family doctor and how should we approach this? And Brian, I wonder if this might be a good time to bring up the OCFP webpage as well.
Thanks. So this is when you go onto the OCFP webpage, that's what you'll come to. Click on the red bar at the top to the COVID tools. And we have just put out a 2-pager around workplace accommodation. So you'll see in those COVID resources, the one on the left is our infographic for PPE. This one on the right is the workplace accommodation. Our role is to describe the condition, and it is the workplace's responsibility to provide the accommodation. We don't say what the person should have. We say what, besides the standard public health measures in a workplace, would be necessary for this person to work and to perform their job. What we've tried to put together here are high-risk conditions, and when you go onto the websites of Public Health Ontario, Public Health Canada, the Ministry of Health, there's very broad baskets of conditions that are at higher risk for serious illness if they contract COVID. And so what we've done is try to put together recommendations from the different specialty groups across national specialty groups that gave us guidance. You'll see that, so for example, pregnancy, it's pregnancy with high risk components. The big one that has come up a lot is asthma. And though the Canadian Thoracic Society has said that asthma is one that would require some workplace accommodation, in reality, that statement was put out in April, and we have a whole lot more information around the representation of asthmatics in serious COVID cases, and they are not more at risk of serious condition. On the studies that have been, there's a couple of studies that have been done over the last published in that would indicate they are not at higher risk. Nonetheless, the Canadian Thoracic Society hasn't yet changed their guidance, and we are hoping that they will, given that it indicated they would be updating it every 2 weeks. COPD does remain on that list. Another thing that is of interest is the disease modifying agents. So are not found to put people at higher risk of serious COVID illness. And if you look at the Crohn's and colitis page, they've got some really nice resources. There's even a letter for patients to bring to their employers, and it's very helpful for you as a physician. So there's a link within that 2-page, which goes over some wording. Prednisone more than 20 milligrams per day is considered the immunosuppressant dose of prednisone. So those are just some highlights of that 2-pager. We did talk about age. Age is 60 plus is a relative increased risk, and of course, as people have additional comorbidities, that increases their risk at both with diabetes. If 40 plus is 40 older with diabetes, older than 40 with other comorbidities are conditions to consider as well. We make some statements at the end as well about anxiety and ways to direct patients. There's the standard anxiety that we all faced when we were going back to work and our families, and we can help a lot of our patients through that anxiety just through our own connection with them and referring them to tools. We have some resources within this community of practice that you could have a look at. And for people though who have really very significant anxiety disorders that where our interventions do not allow them to feel comfortable enough to function normally in a workplace, we have to describe those conditions, and the workplace is responsible for coming up to with the accommodations.
I just want to build on that, Jennifer. Somebody asked, when dealing with mental health and anxiety, if the patient doesn't wish to disclose their diagnosis, can we request accommodation of working from home due to medical reasons, for example, and then the insurance can follow up if necessary?
The latter part of that, the insurance companies may require more details concerning your patient's diagnosis when it's provided, and can be, but it doesn't need to be with the consent of the patient. So the patient can decide that they do not those details. That would be relayed to the insurance company.
Thanks.
So again, the answer
is.
Thank
you, Jennifer.
Yeah.
With the patient, it's really great that it's great that the OCFP has pulled together this resource. I think really helpful for family doctors who are struggling with this, because people are coming in and we hadn't been given guidance on what to do. Brian, I think you can stop the slide now, and I'm going to just go back to I'm going to go to a couple of questions back to schools that I've seen here. So Isaac Bowles, you did email this question to us earlier, and before the community of practice and our panel did discuss it. So Isaac Bowles notes that in appeal document that was posted, there's a comment in the document that says if there's no known alternative diagnosis and the ill child was not recommended for testing for COVID-19 by a healthcare provider, the individual may return to school when the symptoms are resolved for at least 24 hours with no medical note. And he wondered if we could comment on that, and I think Alan Grill as well thought that was a great question. Jeff, I wonder if I could turn it to you, because I think you had a thoughtful response.
Yeah. So the document that was being referred to was from Peel Public Health, and I believe that. So I read the document, and I think, at the first page, it says, anyone with symptoms should go to get tested for COVID. And where, Isaac was referring to was at kind of the last page. They had a box where they were kind of listing all the scenarios. So ideally, they would have been tested, but if they didn't get tested, and, if we have an alternative diagnosis and then you wait till their symptoms are resolved, then they can go back to school. And so, but even if they don't have an alternative diagnosis and they didn't get tested, well, you can't keep them home forever. So I think it was written that way just to say, they can actually go back to school, after their symptoms, like 24 hours after their symptoms have resolved as well. That's obviously a suboptimal situation. Ideally, everyone would get tested. We would know yes or no if they had COVID or not. But in the event that there was a kid, who didn't get tested and we don't have an alternative diagnosis, they eventually will have to go back to school. So they just have to say, okay, well, wait till they're symptom free, add 24 hours, then they can go back to school. So I think that was my read of that document was kind of the rationale for why they said what they said.
So, there's some follow-up question and dialogue here. So Alan Grill says, I don't think we can send people back to school without a COVID test, even if we think there's another diagnosis. That's why we have a screening questionnaire. So if there is no test, no return to school unless they want to stay home for 14 days. And then a few people are saying, yes, I agree with Alan. So I don't know if you want to comment on that. And maybe, and Brian, I wonder if you could just put up the school outbreak management slide as well. Go ahead.
Yeah. I'll just quickly say, I agree with that. Just because you do have, something else doesn't exclude a potential co-infection with COVID. So even if there is like strep throat or otitis media, it could also be COVID as well. So I agree with Alan that it would be a good idea for everyone who has any symptoms to get tested for COVID, just to make sure that they don't have COVID, in addition to some alternative diagnosis.
So,
go ahead.
Yeah, I think there was also a question about whether or not people should stay home if their child is being swabbed. So, the child, is not considered a probable case unless they were actually exposed to somebody with known COVID. However, I think the most public health units are recommending that close household contacts of a person with COVID-19 symptoms should also self-isolate and arrange for COVID-19 testing, because we know that household transmission is really a high-risk area of transmission. So I know that a lot of workplaces, including our hospitals in the province, are struggling with how to support people who need to be home because their child either, let's say, is positive, or the child's been exposed, or the child is, you have to miss a couple of days of work. But I think a lot of workplaces are struggling with how to support those people financially who are off, not because they're sick themselves, but because they have somebody in their house that is undergoing testing.
Yeah. And I just want to add to that, David. I think, what you said is absolutely true. If your child has symptoms, then it's probably a good idea for everyone in the household to stay home. If your kid is sent home because they've been exposed to a case of COVID in their classroom and they're put into quarantine, then I think it's okay for everyone else to continue going to school or work, because they're not symptomatic yet.
If they're not symptomatic.
You're just a contact of a contact, and then you're okay. But if you're a contact of a case or a probable case or suspected case, then it's probably a good idea for you to stay home. So just to make that slight distinction between a child who's sent home for isolation versus a child who's sent home for quarantine. If they've got symptoms, then that's considered isolation. If they have no symptoms, that's considered quarantine.
Yeah. I think that's a really important distinction.
Yeah. One other question that's related, somebody asked, runny nose, can we have some clarification around runny nose? So a runny nose with a sick non-COVID contact would warrant testing. Also how, sorry, I think as I was reading that, my screen moved. Also had many children been sent home with abdominal pain that is self-resolving within a few hours and isolated without other infectious symptoms? Is this presentation one that actually requires testing and isolation? So I think people are pointing to the fact that there would be obviously vague, broad symptomology that can be associated with COVID, and often these things can be transient or self-resolve, and obviously many reasons for runny nose. I don't know if Jeff, you wanted to tackle that, or someone else?
Yeah, I think it's really tricky. I think if it resolves within a few hours, then probably okay, to not get tested. I think it's a tough question, I would say. I think it depends on so many other factors. It's if it's going to be 8 hours to line up for a COVID test and the symptoms resolve within 2 or 3 hours, and I'm not sure it makes sense to go line up to get tested.
And my understanding too with the runny nose is that if it's known seasonal allergies, that's not a reason to get tested or to be worried about COVID. Jennifer, I know you had a sort of a comment about that symptomology in the runny nose.
Yes. I wish really a black and white, if this then that, and but I would say the runny nose that's related to seasonal allergies, postnasal drip, would be a reason not to test. I think mentioned in your question around the abdominal pain from hunger or constipation. Again, that's really clinical judgment that you would apply and decide, no, I'm not going to test this person. And if the symptoms resolve, then they can go back when they're 24 hours without symptoms. That would qualify.
Yeah, and so, I mean, I think Michelle Albert commented, it's hard to tell if it's COVID or a seasonal allergy, and I'm telling patients that they need to medicate their children with antihistamines this year because there's no way to tell. I will say I've told my own son that he needs to take his antihistamine because I don't want people to think he's there with COVID, so that's definitely a practical consideration. Yeah, and so there is a lot of clinical judgment, and I think that's what Javed is also saying. We need clinical judgment in each case.
I think there's a really interesting question about physicians being tested, about wasting time.
Yeah.
So a number.
So I actually got. No, I actually had a sore throat yesterday, and I had to go get a test, and I was lucky that I work in an institution where I was allowed to make an appointment because I had worked there, but I know that people who are not appointed there wouldn't have been afforded the same luxury.
Yeah, so I was going to say this. So a number of the hospitals, if you're on staff, are letting people with a hospital badge sort of go to the front of the line because they don't, I mean, ideally we don't want healthcare workers not to be tested because they don't want to lose, time in their day. So if your hospital doesn't have that, I think maybe a call to your chief medical executive with a suggestion that they follow the lead of other hospitals around allowing healthcare workers to get to the front of the line so they can get tested and back to work.
I also see that Alan has written another comment back around that school discussion that if a kid gets sent home because they're a close contact to a positive case and need to be self-isolated for 14 days, even if they're asymptomatic, they need to self-isolate properly. And if that can be done, doesn't it impact their own close contacts at home? I don't know, Jeff, if you want to build on your previous response there.
Yeah, I think it's a tough situation. I think I don't know what to say about that. It's because I think the tricky thing is that, we have to take into account that you may be spreading, before you show symptoms. So some people are saying, we should be testing, everyone, and then if they're negative, you need to have another test if you've had actually a true, a real exposure to a case, because maybe the first test, was a false, like they were just incubating still. And so, I mean, I think it's tricky, you have to use a bit of common sense and, if it depends on like the other members, if they're going to places where they're less likely to spread as well, right? So like, when I come into work, I'm wearing a mask all the time, except if I'm in a room by myself. So the risk of me transmitting to one of my colleagues is probably low, versus if you work in a setting where nobody's wearing masks and there's no physical distancing, then, ideally that's not happening in the first place. But if it were the case, then maybe it would be prudent to, for that person to quarantine, even though you're not yet a contact of a confirmed case. So I think there's some judgment call there for sure.
Yeah. And then, so Ross Kirkconnell actually says the best advice I've heard is, are you 100% confident it is not COVID? If no, then you might want to assume COVID and go get a test. Now, of course, people have also brought out the logistics of getting tested, and lots in the media today about the long line. So we do need to make that testing more available for people. I think there's a question just came up from Parmijit Singh about, please comment on the saliva-based COVID test for children that was announced for use in BC. Will it be coming to Ontario, and what's the turnaround time for those tests?
The saliva testing, was that the question? Sorry, I was trying to read another question.
Just saliva-based. Yes, it's in the chat.
Yeah.
Sorry, it said please comment on the saliva-based COVID test for children, and I guess it was announced for use in BC, which I missed that. And will it be coming to Ontario, and what's the turnaround time?
Yeah, I don't have any specifics about timelines, but saliva testing most likely is coming to Ontario in the near future. So I don't know if it's going to be days or weeks away, but definitely it's actively being pursued. It just needs time to, like, the implementation needs time, just like a lot of things.
Yeah.
I think the other thing, and I was going to say the other thing to realize is, like, you know, if it's, let's say, just like low nasal swabs, it's 10% less sensitive. The question is, where are we going to use the test too? Are we going to use it for screening purposes or diagnostic purposes? Like, if we need to screen a whole homeless shelter or a whole floor of a long-term care home, maybe it's better to use something that's less invasive. We can get a faster turnaround time, and then see if there's actually a signal that there's disease going on, let's say in a school. So I think it's not just about, like, is the test going to be available, but how do we use that test, and is it screening versus diagnostic?
Yeah. So a couple other things. So I think Alan Grill mentioned a Q&A that came out from his hospital to support parents of young kids and what to do around work. And he's going to see if he can share that with us. He also mentioned that Choosing Wisely is working on an antibiotic stewardship document, I think. And so hopefully, ultimately, we'll see that as well. And Alan is mentioning that he is hosting a webinar for family docs in central regions on this topic as well, and he'll share that with others. So Alan, if you get those things to me, I'm happy to share it to our group when we email folks. There is we're running short on time. I do want to say that in the last few minutes, if you have suggestions for future topics, if you can put them into the chat, that's great. You will also get an evaluation after this webinar, but not everyone fills out the evaluation. We'd love to get your evaluation, and so please do fill it out. But if you know you're not going to, then just put your suggestions for topics into the chat, because it really helps to inform what speakers we invite and how we structure things. I think we won't have time to answer all the remaining questions. I did see a couple of times a question around sensitivity of the COVID test, sensitivity and specificity of the current COVID test. So maybe I'll turn it over to somebody here to answer that one.
Yeah, my understanding is that the specificity is extremely high, like 99%, but the sensitivity might be lower. I've heard, maybe 70%. And I think the challenge is maybe, it's hard to say whether it's the inadequate sample. Maybe it's not like a true NP swab that's collected, maybe somebody pulled back, when you're inserting the swab. So that's what I've heard. And there have been cases where, somebody tests negative and then the next one they test positive. And sometimes after positive, you'll test negative and then, positive. So people who have had repeated testing will have, like, sometimes inconsistent results between swabs.
And then there was another question for you, Jeff, around the safety of this new flu cell vax, because people often do have questions about safety and given anxiety around vaccines and the rapid COVID development, if patients are hesitant with the new cell vaccine, do you have any key messages we can use?
Yeah, I mean, I would say that it's just as safe as the egg-based vaccines. Just because it's new in Canada doesn't mean it's actually totally a new product. So like I said, they've been using it in Europe since 2007, in the US since 2012. And so, we're getting it in Canada now, but just like with the flu mist, they were using that in other settings before it came to Canada. So I'm not concerned about the safety. And I think, you can always check the NACI statement. They'll have a nice summary of all the products. And you can look up the product monograph of flu cell vax and see that it is considered just as safe as the egg-based vaccines.
Thank you, Jeff. So thank you to our panelists for taking the time today and the prep work that you've done in advance to try and get the information that we know so many out there were looking for. Thank you to all of the folks who attended and your great interactivity and all of the suggestions and comments that you've been streaming in. So we do capture all the Q&As and the comments, and we try and reflect those back on our website. So you can check out the website, dscmutoronto.ca COVID-19 Community of Practice. We'll be posting a recording of the webinar there. You can certainly turn your colleagues to that if they want to see it, and we'll have the resources there, and we will also email you a list of resources that were shared at today's webinar. This is an accredited session, and so you will also be receiving your certificates approximately in 1 to 2 weeks, and please do complete the evaluation if you have time today. So we will be having another webinar in October. We have planned these to be approximately monthly. We will put it out on Twitter and our listservs once we have the exact date, and we'll inform the topic based on your comments. So thank you, everyone, and stay safe.